Dr. Mark Assmus is one of my famous fellows. He did the 2-year fellowship. So we started in Indiana and finished here at Northwestern. He did his medical degree in urologic residency at the University of Alberta. He also did an MPH as well through Indiana at the Richard Fairbanks School of Public Health. And then, as I stated before, he did the Endourology Fellowship, finishing here at Northwestern with me. He's a superb surgeon. He's excellent at kidney stone disease as well as BPH, and he currently is in Alberta at the University of Calgary doing their complex kidney stone surgeries, as well as starting the first whole-up surgery in the province. So he's very well known there and extremely busy. He does quite a bit of research as well, did a lot of research with me and continues to do research in his practice today. And today he's going to be speaking about updates on surgical technologies for upper tract obstruction. So you'll be giving your presentation today, but it will also live on the website so that people can view it in the future. And Mildred, this is CME credit as well, correct?
That is correct.
So everybody benefits here. So I'm looking forward to it, and I will turn it over to you, Mark, and we'll see what you are presenting today.
Thank you so much. All right, so thank you for giving me the opportunity to present on advancements and breakthroughs in endourology talk, focusing on surgical technologies for upper urinary tract obstruction. I have nothing to disclose. Some of the cases and slides that will be presented were adapted from other presenters with their permission. And just a special thanks to Dr. Matt Lee and Shubha D, who provided some valuable content for this talk. Dr. Krambeck highlighted it perfectly. I grew up in Canada and was fortunate to come back home to where my family is to be working, thanks to training with her, battling through tough stone cases and massive prostates, and continue to do that here in Calgary. So in this talk, we're going to review what makes miniPCNL different from standard, touch on some of the outcome comparisons between the two, and then highlight a couple real-world cases where miniPCNL has been utilized. We'll discuss some innovations in flexible negative pressure access sheath systems, and we'll touch briefly on progress with first wave lithotripsy, and interspersed throughout the talk, we'll talk about challenging cases of stricture management or radiation strictures, possibly some tips and tricks, although they're challenging no matter what you do. So we all know that percutaneous nephrolithotomy is particularly valuable for the management of large stones. It's the gold standard for managing stones more than 2 centimeters in the majority of cases. And historically, it was most commonly performed through a 30 French sheath. The major downside to PCNL is that although rare, major complications can occur, and these are typically focused around bleeding complications and infectious or urosepsis complications. And although embolization is quite rare, transfusions do occur, roughly 1% of cases, and many patients that are undergoing PCNL have at baseline quite complex comorbidities where you are really trying to minimize clinically significant bleeding or infections to avoid morbidity and mortality in these patients. So one of the many things that urology has looked at to reduce these risks of bleeding and infection is the impact of sheath size, and whether or not reducing sheath size can help improve outcomes but also allow us to tackle these larger or more complex cases. This is not a new concept. The term miniPCNL was coined a couple decades ago, but it's recent improvements in urology in general, but specifically endourology, that have improved our quality and sizes of our scopes, high-powered lasers, new irrigation systems, and all of these continue to improve the use of these smaller sheaths while tackling these large stones. One of the unique aspects of managing stones with miniPCNL is the concept of the Bernoulli's principle, where essentially you have a front of low pressure creating a pseudo cavity in concept that is produced at the tip of the nephroscope that allows you to then extract stone fragments once they've been lasered or broken up into small enough pieces to pass through the sheath, and allows you to suction irrigate them out the sheath without requiring grasper devices or baskets, which may obstruct the flow and visibility. And we'll show a video of this, I think, later in action in the talk. Multiple studies, systematic reviews, meta-analyses have examined outcomes of miniPCNL versus standard. And overall, in the majority of cases, the miniPCNL can obtain roughly similar stone-free rates while reducing bleeding risk, which is in most studies offset by a potentially longer operative time. However, ongoing novel irrigation and suction techniques continue to improve intraop efficiency and efficacy of miniPCNL stone removal. And one of the areas where I think miniPCNL really shines is the unique anatomic situations, which we'll talk about in the coming slides. With respect to length of stay benefits of miniPCNL, many studies show safe discharge same day or ambulatory PCNL in standard size sheaths for most patients. And so the benefit of miniPCNL may be less than was previously shown in the literature, where standard PCNLs were staying in hospital for a number of days or at least overnight. But at least it does make sense that we know by decreasing sheaths from 30 French to 20 French, we can decrease the volume of that renal parenchyma that we're actually dilating by 45%. And studies looking at PCNL access scar sizes and parenchymal volume loss have questioned whether this is clinically significant. One study from Tract looked at the mean estimated scar volume of 30 French sheaths versus 11 French sheaths. And not surprisingly, there was a larger scar with the larger sheath. However, the overall volume loss relative to the total renal volume was so minimal, it's hard to understand whether there would be a long-term implication on renal function or chronic kidney disease rates, and that's not fully understood. So practically speaking, I find it's the medium to large stones, particularly in an anatomically challenging situation, where I feel miniPCNL can really shine. This includes scenarios like infundibular stenosis, calyceal diverticulum, horseshoe, pelvic, or ectopic kidneys, patients with stricture disease, or significant BPH that you can't manage concurrently for some reason, reimplants, conduits, or transplants. So in all these cases, no matter what you're doing, it's going to be more challenging. And potentially, if you have a transplant kidney and you want to reduce the risk of major bleeding, transfusion, or embolization, you'd be looking at considering whether you can tackle the stone with less bleeding risk with a smaller sheath size. Similarly, some infundibular stenosis or calyceal diverticuli stones will be such a small little area that you're targeting. Try to ram a 30 French sheath into that is going to be quite disruptive. They likely have a lot of irrigation spilling around your collecting system, and have to manage that afterwards. So to discuss miniPCNL in unique situations, I have a few cases that I'd like to walk through. The first is a case of a 52-year-old female with rheumatoid arthritis, recurrent urinary tract infections. She was admitted to hospital for a complicated renal abscess with a stone that may have been impacted within a narrowed infundibulum. And the patient was managed by a medical team. They placed a perc drain into the abscess with antibiotics, and then subsequently referred the patient to urology tube-free. So post-drainage of the abscess and after completing the antibiotics, there's this 1.2 centimeter stone with resolution of the abscess. And at this time, as many would, we attempted management of this by ureteroscopy. However, as you see on the left, the scope could get up to the collecting system, but on retrograde, there's no filling of the calyx with the opacified stone, and there's no ability to identify the narrowed infundibulum that the stone was contained within. Unfortunately, a reasonable option of conservative observation failed due to recurrent urinary tract infections requiring the patient to hold medications for rheumatoid arthritis, resulting in recurrent rheumatoid flares. And subsequently, surgical stone removal was revisited via a percutaneous approach. And in this case, you have a small stone within a non-dilated, small, narrowed infundibulum calyx. in a young patient who was otherwise reasonably healthy but having recurrent infections with rheumatoid arthritis. So this case was done supine with the aid of a 16.5, 17.5 mini PCNL sheath, and the TFL laser was utilized for this case. So here on the left, you see this is a rigid mini PCNL sheath directly into the calyx itself, allowing for placement of your scope onto the stone, and the TFL laser is used to break up and suction out, with the aid of the pressure and the scope size differences, the sheath allows the stone fragments to irrigate out. And once the stone is fully lasered out of this calyx, then you can start looking at finding the narrowed infundibulum using a combination of wire sounding, contrast, methylene blue, retrograde or antegrade approach. On the next video on the right, the left side is the retrograde ureteroscopy, coming up into the collecting system and finding the now dilated infundibulum, and then the mini PCNL access sheath, and the right video is through that access sheath with an nephroscope. The quality of the video might not come through excellent, but it's still always fun to see the tip of your scope through your axis, through a dilated infundibulum that you previously couldn't even find. So post-op CT showed no hydro within the calyx, and the patient achieved a stone-free state with no infectious complications or major bleeding. And at 6 months post-op, she's actually had no urinary tract infections. One of the concerns about mini-PCNL is increased pressure, and increased pressure leading to increased pilovenous back pressure, and theoretically in patients with recurrent infections you may be increasing your post-op infection or sepsis rate or SIRS rate, and that's the trade-off to some degree about reducing the sheath size to reduce bleeding and parenchymal injury, but possibly having less control over your intrarenal pressure, although we still don't know clearly how that impacts your infection rate or parenchymal damage long-term from high pressure during procedures. So another unique anatomic situation where I find I'm often looking at mini PCNL axis is management of complex upper urinary tract strictures. So this is a 70-year-old patient referred for radical cystectomy, left hydro on the CT with a declining GFR, and some recurrent urinary tract infections as well. So on imaging, you can trace this dilated ureter down to the anastomotic stricture. The patient had been referred to interventional radiology and was managing with a neph tube chronically for a year. Antegrade nephrostogram at that time showed no contrast to the conduit, and in many cases with nephrostomy tubes, the insertion site into the collecting system was not necessarily ideal for aiding our surgical access. In this case, the patient was frustrated with chronic neph tubes, infections, and had developed a lower pole stone, which is just highlighted there, and wanted to attempt endoscopic management of both the stricture as well as the lower pole stone. So given the size, location, need for antegrade ureteroscopy, we selected a 1618 French mini PCNL site into the lower pole. In this case, in the middle picture, we're using a negative pressure flexible percutaneous access sheath, which we'll be talking about in more detail. And through this mini PCNL sheath, we could utilize a flexible ureteroscope with a holmium laser and manage to dust the stone, irrigate it out through the sheath, and then get our scope down to the distal ureter to manage the conduit stricture with laser, balloon dilation, and stenting. Similarly, this young patient underwent a complicated ureteroscopy for a significant impacted proximal ureteric stone by one of my colleagues, a 25-year-old patient. The patient's stent was left indwelling and then removed a month later with post-op imaging showing the left-sided hydronephrosis. An attempt by an on-call urologist to treat and place a retrograde stent failed to a blind ending ureter. An F tube was placed, and an antegrade nephrostogram showed no ability to place an antegrade stent. the patient was referred to myself for consideration of endoscopic management. So in this case, we were again able to use a 16-18 French miniPCNL sheath. There's no significant stone burden within the collecting system, and so we didn't need a large nephroscope or a shock pulse or Trilogy to manage stones. We were able to minimize our bleeding risk and parenchymal injury in this young patient. And in combination with retrograde ureteroscopy, we delineated a 1 centimeter stricture between the proximal ureter and the renal pelvis or proximal ureter. In this case, post-op neph tube was left in place after we were able to laser through, balloon dilate, and stent across. We lasered scope to scope across that stricture. And then once we had a stent in place and he went home with the neph tube, we then clamped the neph tube prior to a stent exchange, which he tolerated. At that time, the neph tube was removed. A second new stent was left for an additional 6 weeks prior to being removed. And he's remained asymptomatic post-stent removal with no hydro on imaging and pending a CT urogram. So I personally have not utilized this robotic platform, but in the world of upper tract technology, I'll just briefly mention that a recent Journal of Urology publication a couple of weeks ago reported on the first 13 patients to undergo robotically assisted percutaneous nephrolithotomy in combination with ureteroscopy. We looked at 13 cases with an average linear stone burden of about 3 centimeters. This is a very select cohort of patients, average age 65, BMI of 26. And 12 of the cases were successful. Unfortunately, the final case had a power cable pulled and damaged. There was no ability to replace it. There's no technology-related harm that occurred in any of these cases. And on the top left is the robotic setup. Panel C shows the surgeon console for controlling the ureteroscope, suction catheter, laser, and robotic basket. Panel E shows the papilla selected target for needle access. And this platform uses an electromagnetic targeting system to facilitate the precision of the percutaneous needle access. So through the access sheath, they insert a suction irrigation catheter that can be robotically controlled, and then proceed with ureteroscopy using a holmium laser in a retrograde fashion through the ureteroscope with intermittent suction and irrigation through that percutaneous access. 8 of the 13 cases required robotic basket extraction of fragments. It took an additional 19 minutes of robot docking time. All of the cases achieved a perc access in one single attempt. There were no Clavien Dindo 3 or higher complications at 30 days. However, the average case duration was over 3 hours. Looking at their outcomes, only some of the patients had their follow-up imaging reported with a definition of absolutely stone-free, 2 millimeters or less, and 2 to 4 millimeters for fragments that were retained. So next we'll touch on novel access sheaths that include negative pressure aspiration. Now, realistically, most of us don't have the ability to purchase a robotic-assisted PCNL platform tomorrow to start doing cases. However, adopting and implementing these novel access sheaths is something that we can do and is both clinically exciting and accessible to most urologists. So whenever we're thinking of new procedures or new technology in practice, it requires considering what is the motivation that exists in order to change something. What is the efficacy of a new product, and then what is the safety of it? Ureteroscopy is an excellent way to manage upper urinary tract problems. I'm sure all of us enjoy, a satisfying ureteroscopy case. Improvements in scope design, visualization, reusable versus single-use scopes, improved laser technologies, TFL, pulse modulated holmium. These have all greatly improved how we are managing upper urinary tract diseases. However, despite this, there's still no clear data on what the best approach or safest techniques are with regards to dusting versus fragmenting, sheath versus no sheath, and the impacts of temperature or pressure during our cases. Anecdotal cases of Strictures from novel laser settings and the impact of pressure and temperature on the urinary tract still remain a focus for future research. And despite all these advances and visually, intraoperatively feeling like we clear most of the stones, our stone-free rates are not truly as great as we would expect. So multiple studies have examined long-term stone-free rates and recurrence after various treatment modalities. In a stone-free general population, 70 to 100% are stone-free at 12 months, but drops to 29 to 94% at 36 months. And various studies have reported that between 50 to 75% stone-free rates on early CT follow-up post-treatment, with many of these residual fragments going on to reintervention or further growth. If you look at one study, 44% with residual fragments went on to have a stone event of some sort of symptomatic nature, and 29% went on to need reintervention for these. Additionally, residual fragments that are over 4 millimeters are unlikely to pass spontaneously at 1 year. So I'm sure all of us have come across a case where we got to a lower pole stone, lasered it into pieces that we deemed to be insignificant, and then are frustrated to have follow-up imaging persistently showing ongoing residual fragments that don't spontaneously pass or continue to grow. Negative pressure ureteroscopy may help tackle this frustrating problem. There's many proprietary names for adding negative pressure to your ureteroscopy case. There's CVAC, SURE, IPCP, numerous different companies and brands. However, there's not a lot of long-term strong data on the use of this novel technology. Solano did a narrative review examining suction techniques and found that suction irrigation in a few select studies did provide high stone-free rates, reduced OR time relative to standard ureteroscopy, and suction irrigation also was associated with lower rates of post-op fever, SIRS, and sepsis. Now, most of these are small studies that need to be further examined in prospective RCTs. So there are different ways to accomplish negative pressure irrigation. This could include placing a suction catheter alongside a ureteroscope with an Assmus sheath for passive suction, or after lithotripsy has been completed. You could include an Assmus sheath themselves that have suction, or some ureteroscopes have been approved which contain suction built in. So there's a lot of different technology being examined and developed within this suction realm of removing residual fragments or dust. And if we look at one system here that's highlighted, the CVAC, it's a steerable vacuum irrigation catheter system, uses a 7.5 French inner vacuum lumen and then an outer 12 French irrigation lumen. It can be passed through a 12-14 ureteral access sheath. With regards to the use of something like this, obviously if you're using a 12-14 access sheath, the question becomes whether patients need to be pre-stented or not. How many patients can you actually plan to utilize this in without pre-stenting? And on the right, it just shows the surgeon manipulating the steering through this control dial that allows you to deflect and angle your suction and irrigation tip. So one of the flexible suction access sheaths that's available in Canada and the US is the Clearpetra sheath from Well-Led Medical. They have both ureteric and percutaneous access sheaths. And within ureteric, they have all your typical sizes, 10, 12, 13, all the way up to 13, 15 French, and from 35 to 55 centimeters in length. On both the ureteric and the percutaneous sheath, you have this 45-degree angle port that allows suction attachment. And that can then run through a specimen container and go to wall suction or a device like Neptune. The surgeon can open and close a thumb vent to allow for control of the suction. And typically, the suction will be running as 200 millimeters mercury, and then through the scope, we'll be running something like pressure irrigation at 150 up to 180, depending on the visibility in the case. So one of the additional features of these novel sheaths is not just the suction capability, but also the flexible tip. It can allow additional deflection of scopes to get to challenging stone locations that you couldn't otherwise get to with a standard rigid sheath. We again have all done that case with a big hydronephrotic kidney with a stone that's not complicated, we just can't seem to get to it. You'd love to laser it or basket it out, but no matter how much you try to double deflect, through the dilated system, you just cannot get control of your scope to remove it. Now, with the aid of these flexible sheaths, you can actually intermittently advance your scope, direct the sheath, re-advance your scope, and continue to deflect beyond what you would typically be able to with just the scope itself. And similarly, with the ability to aspirate and suction, you can pull a stone and dilated system towards your laser tip. So if you have a very hydronephrotic system and you're at the extent of how you can advance your scope into that, and your stone is visible but it's too far away, and you're pushing your laser fiber out and it's hanging out the tip of the scope, alternatively you could use a suction axis sheath to intermittently pull that calyx or dilated system and stone towards your laser fiber tip intermittently throughout the case. So these novel suction irrigation axis sheaths are very exciting, and personally have been working great in select cases, but we need some high quality studies to really answer the questions of their improvement in stone-free clearance versus standard. And as laser technology continues to improve and our ability to dust and irrigate stones can become more efficient, there is a potential for reducing basketing time, intra-op, or operative time to better improve our use of OR resources. I know for myself there are certain lower pole calyx stones where I've already initially been thinking about a PCNL or mini-PCNL, and now I'll consider attempting it with ureteroscopy with the suction axis sheath to see if you can avoid the morbidity of a PCNL in complex patients, even though most do well. And as I mentioned previously, we still just don't have a good understanding of the impact of pressure and temperature exposure within the collecting system. And with these newer high-powered lasers, understanding whether suction irrigation systems can reduce any of these risks will be interesting to explore. So next we'll touch on current information available regarding burst wave lithotripsy technology. So what is burst wave lithotripsy? This is a novel use of ultrasound energy that was initially developed to serve as an adjunct or potentially a treatment to non-invasively managed stones. The goal was to create a handheld technology that would not require an anesthetic. And with respect to not requiring an anesthetic, we will highlight the implications of that in the coming slides, because one limitation of this technology is avoiding traversing bones like the pelvis and ribs, which can be incredibly painful. So BWL is licensed and commercialized by Sonomotion. It was FDA approved for trial in December of 2022 and received Health Canada approval for trial that same year. The handheld device includes a central imaging transducer, like a standard ultrasound probe, followed by a larger surrounding treatment transducer. So these are two videos that many of us have seen and get everyone excited about the concept of the technology. On the left, you're using the BWL to fragment away the stone into dust, while on the right, you're using the energy to reposition a stone or pop it out of an inaccessible lower pole to, or for example, if it was in a symptomatic renal-pelvic location, to theoretically pop it out of that location to manage the stone electively in a non-emergent fashion. So how does shockwave lithotripsy compare to BWL? Well, when we look at shockwave lithotripsy, it's usually performed using both fluoro and/or ultrasound, and often requires a fixed or large mobile unit with portability challenges or coordination issues. Here in Calgary, we perform all of our shockwave with a light sedation, with many cases requiring a GA in the United States. And in comparison, the goal of BWL would be to avoid any anesthesia requirements. The characteristics of the ultrasound energy is different between the two. So shockwave lithotripsy has a high peak pressure at a low 1 to 2 hertz frequency, while BWL uses high frequency and low amplitude. BWL treats the stone by sort of dusting the outside of the stone, breaking off small pieces as it works its way toward the center. And shockwave does this as well, but there's some spalling as well that can burst the stones from the inside into more fragments. So this study first reported human cases in 2021, They reported on 2 cases. One was a renal stone, 7 millimeters, in a patient who was planned for ureteroscopy, underwent 9 minutes of BWL treatment prior. The BWL in this case was done under a GA, and the pictures on the right show what the stone fragments looked like after the 9 minutes of treatment when they went up with the ureteroscope. The second patient had a ureteric stone at the UVJ, treated for 10 minutes. They then passed the stone a couple of weeks later. However, the stone was intact, so the BWL may not have done anything to treat the stone or break it up. However, at least this study showed proof of concept that it could be used safely in these 2 select cases. So after the initial proof of concept study, they went on to examine 19 cases, and of note, complete fragmentation was defined as less than 2 millimeters. It did observe some mild tissue oozing and injury with ureteroscopy visualization, but there was no major complications. And regarding the safety of BWL, one study looked at porcine data for shockwave versus sham versus BWL, and this article was published in Journal of Endourology, showing very little intrarenal or tissue injury with the sham or BWL versus shockwave lithotripsy, which did have some injury. So currently there's a trial ongoing in North America. These are patients already planned for stone treatment with either ureteroscopy or shockwave. The stone had to be less than 10 millimeters and could treat to a max of 30 minutes with BWL prior to their definitive treatment. Preliminary reports from the trial have been presented recently. They managed 44 patients that were included, both renal and UVJ stones. And with respect to their anesthetic levels, 4 patients had a general anesthetic, 2 of the 44 had conscious sedation, and 86 were deemed to have had no sedation with either a mild anesthetic, which in this case could be IV ketorolac, or no medication at all. So they reported their overall success in yellow, as well as the cases that they defined as optimal success, given that they were on a learning curve and this was a novel use of technology. So overall, their results are not bad, with 4 millimeter or less fragments on post-op CT in 75% of patients, and around half of the patients were completely stone-free. Stone-free for the UVJ stones approached 90%, but it's hard to know how many of these could also have spontaneously passed without treatment, and further comparative controlled studies will be required. The largest barrier to BWL use is that the stone must be visible under ultrasound, and to minimize pain from traversing bone, you can be limited to only select parts of the urinary tract. In many patients, the lower pole, mid-pole, renal pelvis will be easily accessible, but the ribs might obscure your upper pole stones in many patients. Bowel gas causes issues during the mid and proximal ureter, and pelvic bones again prevent mid-ureter treatment. And it can be somewhat effective towards the distal ureter and then visible often on the UVJ located stones. Again, this is dependent on the provider's familiarity with the use of ultrasound. However, many endourologists are increasing their ultrasound skills for ultrasound-guided PERC access, and in general, this might be something that further increases our desire to take on learning handheld ultrasound. So Sorensen presented at this past AUA on RCT evaluating propulsion of stones. The focus of this study was to try to migrate stones from a calyx out of the kidney. They found there was a 61% lower relative risk of a composite outcome over a 2.6-year follow-up, and many were able to achieve a stone-free state. Their composite outcome included surgery, symptomatic unscheduled events to the emergency department, clinical visit, and stone growth. So with respect to future directions, this is still a long ways off from day-to-day practice, unlike use of the suction aspiration access sheaths. And although the videos of blasting a stone and propelling a stone look awesome, in practice it's much more challenging, and skill with ultrasound at baseline is crucial with each provider. After the ongoing trial concludes, if there's a positive outcome, it'll be important to compare to alternative control and treatment arms in large prospective studies. And safety data is crucial, and it'll be interesting to know whether case variation like skin to stone distance and composition of the stone impact your outcomes. So I just wanted to finish today's talk by talking briefly about strictures and radiation. In some of the earlier cases, we already touched on endoscopic treatment of enteric strictures or post-op strictures. And I don't know what I did to get so lucky, but I seem to be flooded with referrals from providers having radiation strictures. So I'm not trying to pick on gyne-onc here, as there's many of our own diseases which receive radiation treatments and go on to become challenging stricture cases. But this recent review article identified ureteric strictures post-chemoradiation standard of care plus high-dose brachy for cervical cancer, resulting in 1.5 to 4.4% of patients having strictures at 5 years. And the rate of stricture continues post-treatment beyond the high-risk 5-year period at a rate of 0.15% per year. Despite these surprisingly high rates and the number of patients and cancers that are being treated with radiation, a lot of them are managed conservatively. Some undergo, chronic nephrostomy tubes or stent exchanges, and only 3.2% of those patients go on to have severe complications requiring urinary diversion or nephrectomy or reimplant. So as I mentioned, many of these patients will be managed with chronic stents, although the failure rate is unclear. One study found a 50% failure rate of urinary tract radiation strictures managed with stents, while another study found that radiation made no difference versus non-radiated strictures, with an overall stent failure around 28%. And chronic stents themselves are not without their own risk. Dr. Krambeck published a paper on a ureteroiliac artery fistula due to chronic stenting. So although this can be effectively temporary for some patients, it's not without its failure rates and rare complications. With respect to my general management approach, I typically aim to laser incise the entire length of the stricture. I prefer TFL for hemostasis in the ureter, 0.6 and 16, or if I'm using a pulse modulated holmium, I'll stick to 0.6 and 10. I then typically will balloon dilate to accommodate an endopylotomy stent or 2 side-by-side ureteric stents, with an aim to rest the ureter and downsize it to a single 7 French stent approximately 8 weeks later. That second stent will, depending on how things look, come out with plan for CT urogram plus or minus renal scan versus an intra-op assessment depending on the case. So I just wanted to finish by highlighting a complex radiation stricture case of both the upper and lower tract. This is a 60-year-old man who had prostate cancer. Post-treatment, he went on to have severe urethral stricture, prostatic fossa, dystrophic calcifications throughout his bladder, recurrent infections. He had multiple failed surgeries, attempts to treat things retrograde. Most urologists were unable to manage his prostatic calcifications, and many times the urologist failed to identify a ureteric orifice at all or couldn't exchange his stent once they removed it. His renal function was declining despite his stents, suggesting extrinsic compression beyond what the stents could accommodate. And initially the patient was extremely resistant to neph tubes. However, eventually after numerous failed surgeries, declining renal function, he was accepting of bilateral neph tubes and then was referred to myself. He also had severe bladder pain when he did have the prior stents and was very adamant that he would want ureteric stents for the least possible duration. So this is just a very blurry pre-op CT showing how abnormal his prostate was. There's these dense calcifications and rind within his prostate, as well as internal, more central located calcifications. And again, you can see here, this is the start of his bladder above the atypical prostatic fossa, and at this point he had accepted the bilateral nephrostomy tubes for drainage proximally. He was resistant to any antegrade percutaneous approach to manage what was thought to be bilateral ureteric strictures. And as with any complicating case, the focus is on patient education, understanding, trying to push them towards realistic goals for expectations of treatment, and understanding that oftentimes in these complex cases it's going to be 2 steps forward, 1 step back, and may require multiple procedures to get a safe and reasonable outcome. So a few days prior to surgery, IR antegraded stents. It was the shortest duration that he would accept prior to surgery. He suffered with the distal stent pain within his hostile bladder. We were able to bring him to the operating room and shoot this sort of retrograde urethrogram, and you can see that he had a almost obliterated urethral stricture proximally just below his prostatic fossa, but contrast did get up into and fill that prostatic fossa and start of the bladder. And here is 8 millimeter proximal urethral stricture with contrast going up into his prostatic fossa. We're able to, luckily under direct visualization, place a wire and then laser and size and dilate to accommodate our scope. And on this retrograde, it's quite interesting to see he had all these filling defect stones and calcifications embedded within his prostatic fossa and capsule. And it was extremely challenging to get the scope in past all this dense calcification. Once we were able to get proximal beyond the urethral stricture with our scope, we struggled to do anything. We were essentially completely locked within this rock hard prostate, unable to do anything to get to both right or left ureters to manage the strictures. So at this time, we actually elected to do a holmium laser enucleation of the prostate, getting between the calcified rind and the capsule. You can actually see here, as we were enucleating, we were bringing this calcified prostatic necrotic tissue as well as his brachyseeds medially towards the lumen of the urethra, while trying to very delicately stay from perforating through his radiated capsule. Surprisingly, at the conclusion of lasering, morcellating, and irrigating out all this debris and stone, we were finally able to get around within his bladder. And at this time, we found the previous ureteric stents, elected to dilate the ureteric orifices, upsize the stents prior to a planned secondary procedure to see whether or not he could actually even tolerate stents within his new stone-free lower urinary tract before proceeding with more aggressive treatments. My thought was that if he is unwilling to accept or can't tolerate stents long term, then more aggressive therapies to try to treat and get to a neph tube free state is unlikely to be beneficial. And so at this time we injected bladder Botox and concluded his case. Surprisingly, he tolerated his new ureteric stents perfectly after we had enucleated that sort of dystrophic calcification. And unfortunately, upsizing the stents was not adequate for antegrade drainage. We had attempted neph tube clamp trials and antegrade nephrostograms, which failed, so we elected to proceed with a second surgery. At the time of his second surgery, I was shocked to see sort of how well his lower urinary tract had reacted from enucleating all that scar and tissue out. You can see his proximal urethra and then coming towards the start of a reasonably healthy start to his prostatic fossa. And at this time, we proceeded to evaluate and manage his distal bilateral ureteric strictures using a combination of sequential rigid dilators, laser incisions, balloon dilation of the distal ureters prior to upsizing to new stents. We also discussed risk, benefit, and evidence for, and ultimately proceeded with injecting steroid triamcinolone, 40 milligrams reconstituted in 5 mils of normal saline 50-50, surrounding the scarred tissue around his bilateral ureteric orifices, and subsequently new stents were placed. And in follow-up, he's been able to tolerate safe and sequential bilateral neph tube clamping, subsequent removal, and is now managing with chronic ureteric stent exchanges comfortably and happy. Obviously, in this type of a scenario, I don't think that I fixed his problem. I got him to a quality of life that is reasonable, and time will tell when we'll be back at it again. So thank you, and I'm happy to take any questions.
Well, that was a great presentation, Mark. You covered a lot of material, so I really appreciate it. With the burst wave lithotripsy, are you one of the treatment sites for that?
No, I've been to in Vancouver is, I think moving forward, it'd be something that we could do quite easily within our setup here. And so we'll look to see what the conclusion of their current study is and hopefully be involved moving forward.
So we are one of the treatment sites here, and I'd have to say we have screened probably, I would say 60 patients, and they have allowed us to treat one patient. And they all met the like written inclusion criteria, but they like the acoustic window is too big or too small, or so I don't know how this can practically be used in reality if it's that stringent of a criteria for treatment, because it has to be just perfectly placed, I think, to get this to work.
I agree 100%. Everyone sees the stone pop out of that one pole in a single video and thinks, oh, there, we fixed all symptomatic renal pelvic stones and we can just do elective uroscopies. And the reality is just so far from that in practice. And it's still an interesting technology to consider, but yeah, it's hard to know if it would ever make it to mainstream.
Yeah, and the one patient we treated, it took over an hour to treat the stone, and then the patient still had stone left that we are monitoring. It broke it in half, but it's still in the kidney, and that's like a year later. So, I don't know. Maybe first generation it gets better and better and better, but I don't know how you would practically use that in the emergency room or something like that. So,
yeah, I agree 100%. And then similarly with the robot, these are interesting technologies, but in contrast to the suction access sheaths, they're quite different.
Okay, so how excited are you truly about the suction access sheath? I absolutely love that. Love it. Like, we don't open baskets for many of the cases now. Like, are you having the same experience?
Yeah, both the TFL and the high-powered Moses, like holmium laser, are just so good at treating stones with good visibility. If you can just break it up and then have something that sucks it. I mean, everyone, at least, I haven't been in practice for long, but I know many years of cases where I was like, I wish I could just suction this stone out or this stuff out of this pole. And now I think that this technology is really getting to that point where we can do it.
Yeah, we've kind of come up with a technique where we use the Moses like turned all the way up. We have pressurized irrigation, 0.3 and 120, and it doesn't necessarily dust. It kind of makes fine fragments, and then you just park the sheath up in that spot and pull the scope back and turn the suction on high. And it just sucks it all out. It's so satisfying. It makes me like your ureteroscopy again when I was disliking it intensely. So it's definitely, I think, a game changer, and I think it's probably, we've tried the CVAC, but I don't feel like it can get as big a chunks out as the Clearpetra.
Yeah, that's the one that we've been using most here, the Clearpetra. So it's interesting to see what the future sort of prospective studies look for. And again, similar with reducing the infectious complications. If you're able to suction out all that debris, all of our anecdotal thoughts are that we're showering bacteria when we're breaking up stones, and then that bacteria is getting pushed back into the patient. And if we're suctioning that out as we go, are we reducing these risks? So it's going to be interesting to see.
I completely agree. I think it's a total game changer. Have you used Clearpetra for PCNL?
Yeah, and similar. I mean, it's hard because to some degree, I feel like the technology lends itself to pushing away from PCNL and doing harder, larger stones in a retrograde manner. And so the role for using it, I find, is more anatomically, or if you have like a huge like upper pole staghorn and you can perk that and for some reason can't get to another stone in a weird calyx, then potentially you could just do a little mini, Clearpetra perk onto that laser and dust it out if you really wanted to get someone stone free in one surgery. So
I think it's great. So Matt Lee dropped a comment. Leave it to him to comment on the cost. He said that he thinks that Clearpetra is way cheaper than the CVAC scope, and it definitely is. For now, there is a pass-through code in the US where you get like a discounted price for the equipment if it suctions. So Clearpetra as well as CVAC, I think even the Wolf scope, because you can suction through that second port, you can get that pass-through code utilized, so it costs less for your hospital to use them. But it's just like the LithoView Elite, the disposable scopes had the pass-through code and they were much cheaper, but then it expires at a period of time. So once they hook you in, then you have to pay the real price. But at least for a few years, you'll get the pass-through code and it'll cost less. So, oh yeah, the specific code is C9761. Thank you, Charlie. So
like cost is always an issue everywhere, here as well in Canada. And I think if you look at just your standard cost of a standard ureteral access sheath and then the cost of a basket on top of that, you could make an argument for the sort of, in select cases, it benefits. Additionally, if your flexible access sheaths are preventing you from damaging your scopes more potentially as you're trying to twist them around to get to a lower pole, maybe you're having less scope cost repairs, or so cost analysis studies are always impossible to really understand, but potentially there could be a trade-off in some cases.
Yeah, I think it's really helpful, like the secondary PCNL. So patients that have residual fragments after PCNL, then you just put it up and you can suction out clot, you can get debris. It seems very helpful in those situations. Okay, Charlie said the code has to be prior authorized and payers may or may not be worthwhile. Medicare, Medicaid pays best. Yes. Very good point. So it really is for the Medicare and Medicaid patients. So
really critical to get it prior auth. You can't just during the case get it used, because you may not get it reimbursed, and then you're out to $3,500 or whatever it costs.
Yeah. Is that for your CVAC? Yeah.
Yes, if you then open up a CVAC device like the Calyxo, then and you haven't gotten it prior auth, then it may not get approved, and you would only be able to bill for a ureteroscopy, and your hospital would lose a lot of money.
Yeah, this is a great point, and I think that is an important thing, whether you're thinking about like a disposable scope or a CVAC, is that it's only the select patients, and you need the prior authorization. So I don't know what I think will happen with CVAC. Only time will tell. When I tried it, I thought the image was not that great, and it was very clunky and heavy to utilize. So, and then I wanted to comment one thing on your prostatic calcification case and stricture. We get a lot of calcifications after HOLEP in radiation patients, and I thought about using like hyperbaric oxygen for those situations. Do you have any experience with that?
This particular patient actually has a home hyperbaric oxygen chamber that they utilize. So I'm not sure if that helps me, but they do use it.
Is it Michael Jackson? He had a home hyperbaric oxygen chamber too. No, but they literally have that in their house. Oh, well, it didn't help the prostate, I don't think, but.
Not initially, no.
No.
I mean, radiation strictures are just a disaster. There's no magical cure that I know of.
No. Okay. Anybody else have any other questions or comments?
I really appreciated your talk on particularly the stenotic infundibulum, that component. I've had some patients who they kind of get these stenotic infundibula, maybe or maybe not with a stone, but they'll have symptomatic colic with it. And I've off-label managed that with an Optilume dilation for a recurrence. Have not gotten any follow-up yet, but some of these folks, you may have to dilate a few times the infundibulum. Can anyone here comment on any good success for getting durability with your dilation of symptomatic stenotic infundibula?
I don't have good evidence for it. Anecdotally, I think if you can convince the patient to have sequential numerous stent changes of varying sizes for a longer period post-op, I think that outcome's better, but I don't think that there's evidence for that. I'm not sure if you just leave one stent once and then take it out, or if you're sequentially changing them for a period of time after, but I typically do like to try to change them.
How large will you go?
If I can get an endopilotomy stent positioned properly, then 15 French.
Okay. So you will definitely go very large then for
Yeah,
that.
or two 6 French stents beside each other.
Okay. And then how long will you leave them with the 2 6 French or the endopilotomy? Will you do like a month or 6 weeks or?
At least 6 weeks, 6 to 8 weeks, and then I'll change it down to a single stent for another 6 to 8 weeks. At that point, depending on what basically just arbitrary intra-op thoughts, I'll either take it out and get imaging, or possibly bring them back to the OR and take a look at it visibly and shoot some retrogrades, depending on a couple different factors there.
I see people that have this that they're really asymptomatic. Like they can stenose an infundibulum and be completely fine. Like it looks terrible on the CT scan, but they have absolutely no symptoms, and they don't have pain, they don't have infection, so we just leave it alone. What is the symptoms that you guys are seeing, like infection or pain?
I had a patient who she had pain. I had done a ureteroscopic, I lasered and then dilated. I left an endopilotomy stent for 4 weeks only, so maybe I didn't leave it long enough. But then she had a good result for about 18 months, and then she started having pain again, just kind of just very kind of mild back pain, but that was worse with exercise. And she had like gone back. She ran a marathon after we did her dilation. She was so happy, but then she had symptom recurrence with pain. So I repeat dilated her with an Optilume and haven't heard back as of yet.
And okay, yeah. So what size Optilume did you use?
Let's see. I used for that. I believe I used a 20 French off the top.
Wow.
I think it was 20 French is what I used. It could have been a 18 if they have it.
Okay. Well, that's.
I remember I looked at what they had and I picked whatever I thought was the most appropriate.
Did you use a single stent at the end, or what did you stent with?
Let's see. So we had no more endopilotomy stents. It was a little bit of just kind of an awkward area to get into. I used sort of an interpolar and like a 90-degree turn. So all I put in was an 8 French stent, and I left it for a month. And then at least 3 months later, she was doing fine.
Okay.
But I did counsel her that, hey, maybe we just have to do this every 18 months or however often.
Yeah, a very difficult situation. I guess worst case scenario, you're looking at a partial nephrectomy. So repeating this every few months maybe isn't that bad. So, all right. Well, thank you all. This was a great talk, great discussion. Love it. And I really appreciate Mark taking his time out of his day to do this. And thank you again.
Thanks so much for the opportunity.
All right. Have a great day.